Hello and welcome to Tinnitus Matters, the podcast where we discuss all things to do with tinnitus. My name's Phil Holmes.
And I'm Christine Nixon. And today we have a very special guest, Chris Brockbank, who is the clinical scientist in audiology and service lead in audiology at Lancashire Teaching Hospitals. We welcome you, Chris, and thanks so much for coming on today to talk about tinnitus.
Yeah, thanks, Chris. We do appreciate how busy you guys are. Without further ado, we'll jump straight in. So how common is it?
It's extremely common. I know I have tinnitus for one. I think you have tinnitus as well.
I do.
It's more common than I think the stats suggest it is. And if you look at some of the stats, they'll say, well, it's 7 to 10% of the population. I think 7 to 10% of the population have troublesome tinnitus. But to be honest with you, I think there's very few people that don't, from time to time, experience some degree of tinnitus.
And is it always a ringing? I mean, you mentioned it was...
Yeah, there's lots of different causes for tinnitus, but by far the most common cause is wear and tear inside the inner ear. And that wear and tear inside the inner ear is the seed from which that tinnitus can then originate in the brain, because what we need to look at is how that pathway works. So the way I normally describe this is that you've got the inner ear, and there's lots of little hair cells in there. I've got my little diagram here of an inner ear model. And let's just briefly explain what this is. If I just chop that off for now, because that's where the middle part of the ear is. And then this part here is the vestibular system, so that's to do with balance. And then there's this little snail-shaped bit here, and that's the cochlea. Right. So if we look at the whole of this structure here, it's about the same size as a baked bean. So the cochlea...
That's small.
It is. It's quite amazing, isn't it? And
It is.
that's half the size of a baked bean. So think about the inner ear as half the size of a baked bean, and crammed inside that, you've got a chamber. So if we unravel this one, it's like a long chamber, and within there you've got 16,000 hair cells that respond to the different sounds. And what you've got are the high-pitched sounds responding at this first bit here, and it goes all the way along to where the low pitches are, and then the nerves come off, and so the cochlea not only turns sound from a sound, that's not sound, is it, into a neural signal. Mm-hmm. So that's what it is. It's a transformer, but also it does this in a frequency specific, so it's a frequency analyzer at the same time. So
Very technical. It's so clever, isn't it?
Incredible.
It is. I'm probably
Incredible.
going too technical too soon here. But,
No. It's
fascinating.
Good, fascinating.
Okay, so normally the bit that wears out first is this bit here. This is where the high-pitched sounds are. So
at the beginning of the neural pathway.
It's at the beginning of this channel.
Right.
It's the first bit here, but yes, it's the beginning of the pathway. So what you've got is these hair cells. They're very, very tiny. They're very, very active little things because they actually physically have to move.
Right.
So they actually physically move, and in physically moving, they then generate the electrical signal as part of that movement. So it means that the inner ear not only generates an electrical signal up there, it actually generates an acoustic signal that can come back out of the ear. Now that's a very, very rare form of tinnitus, because that's an example of an objective tinnitus.
I've heard, yeah,
that's right. Very, very rare objective tinnitus.
Do you get many of those in the clinic?
Very, very few. In fact, on WhatsApp last week, there was it's a specialist audiologist WhatsApp group, and they were saying, I believe there's something called objective tinnitus. And it's funny because when I was first taught about tinnitus, there's two types of tinnitus. There's objective and then there's subjective. So objective is very rare, and it's usually originating from the sort of the outer parts or the middle parts, which are associated with sound itself, because the sound has to then be emitted so that you can actually hear it.
Yeah.
So that's why it becomes objective rather than just subjective. But of course,
so that means that if someone had objective tinnitus that comes out of the ear, that I or you could go up to their ear and we could hear that tinnitus.
Potentially, yes.
Yeah.
That's incredible.
Now, normally with the emissions from the inner ear, you can't hear them, but you can put a microphone inside the ear and pick them up. So I was doing that this morning, actually, on a baby, because what we do is to test newborns' hearing, to screen their hearing, we need to know if those hair cells are doing their bit,
Yes.
basically,
Right.
and working. So what we do is we put a sound into the ear, and then we look for the echo that comes back out. That's called the otoacoustic emission.
So I know we're absolutely veering off here,
We
but
completely
it's
veered off already,
interesting,
haven't we?
so interesting. These babies are, they're fast asleep, and you have to
Yeah,
put.
that's right. They're fast asleep usually, just lying in mum's arms, and you put this sound into the ear, and then you get the otoacoustic emission echo from the inner ear, and that immediately can say, oh yeah, that baby's inner ear is working because the hair cells are working. But it doesn't measure the nerve function.
No.
Okay.
And in some very rare cases for hearing impaired kiddies, it might be the nerve function that's not
okay.
working. So we have to do other tests as well for babies that have been poorly. But so basically, going back to that initial sort of questioning, the vast majority of people have tinnitus because of wear and tear inside the inner ear. And that wear and tear means that the cells aren't working anymore, but the nerves are still connected.
So can I just interrupt you, Chris? Sorry. So wear and tear, are we talking just elderly people, or is it
Yeah, no,
occupational?
Right, so first of all, going back to the babies again, it could be wear and tear at birth.
Right.
Because a lack of oxygen when you're a newborn baby could cause damage to the inner ear.
So you can sometimes think it would just as we get older, wouldn't you?
Yes.
No.
So it doesn't.
Any
It
age.
can be any age.
Any age. If you look at this thing here, you've got a very large, I think it's an artery, but it's certainly I think it's an artery. It's supposed to be, and you can see how big that is and how small that is.
Yeah.
So, you've, as I said to you before, these little hair cells are really, really active in doing their thing there. So they need a lot of blood supply. They need a lot of oxygen, and they need a lot of blood supply to take away the waste products that they generate as a result of being very active. So anything that reduces that blood supply can cause damage to the inner ear. So that's the first point I want to make there. So for example, if you have things that might cause a stroke, so if you're a big smoker or something like that, that could lead to reduced blood supply into the inner ear and can lead to damage of the hair cells, which could lead to obviously hearing, but also tinnitus.
So it's a domino effect, isn't it? From something
Absolutely.
different,
Yeah.
we can expect lots of
it's
issues
a
and
pathway.
problems.
No,
It's a
interesting.
pathway, and what rather than a domino, I like to see it more like a seed
Okay.
that grows. So, for example, the wear and tear inside the inner ear here in the cochlea is a seed, but in order for that seed to grow into something called tinnitus, where we're actually perceiving this noise, lots of other things need to be in play. So, for example, you may have wear and tear inside the inner ear. Most commonly, that's due to age and noise. And that wear and tear, obviously, hair cells are still there. They're still not doing this. Sorry, the hair cells are damaged, but the nerves are still there and they're still firing. So they're attached to the inner ear. And because they're then sending the signal up to the brain then says, where's that coming from? Oh, it's coming from the ear. Therefore, that signal must be a sound. And that is then turned into the perception of tinnitus. So that's how it works. So the seed is the damage to the inner ear, but for the tinnitus to actually manifest, it needs a number of other conditions. So, for example, with me, I've got tinnitus right now in my right ear, and the reason for that is because I'm in such a quiet environment.
Yes.
I can actually hear that. So, for example, if you have a blockage there in the external ear, so that's the ear canal there, then that might be wax or it might be a middle ear condition or something like that. That stops the sound coming into the ear, but it dulls the input of sound.
Yeah.
So what happens then is you get an increase in the volume of the system to try and pick up sound. It's a little bit like if the out of tune radio and you can't quite hear it, so you're turning the volume up, and all you're getting the static. The static's like the tinnitus, isn't it? It's something that's random that shouldn't really be there. As soon as you turn it into a channel, boom, you suddenly get all the sound coming through and things, and then immediately you turn it down, and that's exactly what hearing aids would do. But also, of course, taking wax out of an ear would do that as well. So it's, again, blockages here are one of the conditions that can help the seed here, as in this inner ear that's already damaged, to manifest into tinnitus.
So there's lots of different causes, factors to think about, isn't there? It's not as straightforward as
Oh, no, it's
you have a hearing loss.
Yeah, exactly
or
not. No,
you've
lots of factors
got wax
involved.
in your ears.
Can I just ask about noise and kind of people? Because I mean, I'm a musician.
Yes.
And I'm a drummer, so I've sat behind drum kits, hitting cymbals and drums and sat next to bass amps and things like that. But there's also professions where they're in noisy environments. How much is that a factor?
Oh, yeah. Well, it's less of a factor now because in the 1970s there was the Noise at Law Act, which basically meant that people had to start, they had to start wearing ear protection.
Right.
So when I first started in audiology, though, and this is going back now, I've been working in audiology over 40 years now, but when I first started, there were a lot of pensioners from the war pensioners.
Yeah.
And they're all coming forward because they got noise-induced damage as a result of the weapons and things they were using. And of course, they all had tinnitus as well because of that. So they were coming forward as a result of that. There was also a lot of people who worked in noisy industry.
Yeah.
Like the mills, I suppose, the cotton
mills
mills around here.
Yeah. I mean, my gran, she's quite funny actually because she used to be able to, do all this business like
lip reading.
Well, yeah, exactly. What was his
Les Dawson.
Les Dawson, that's the word I'm looking for. He used to live around the corner from him. He used to do all that business. And my gran was into that. And there was a car park across the road from where she lived, and she could hear exactly what they were all saying, or should you say she could lip read exactly what they were all saying.
It was almost a use. They had to do that to survive socially, to make their working day better.
Exactly.
Than sat at a mill all day. If you can't hear each other, it's so monotonous.
Yeah.
I imagine. So you'd learn to lip read.
Yeah.
So you didn't
So it was
go
very,
crazy.
very loud, or should we say very intense. But although, to be honest with me, my gran's hearing was remarkably good.
Considering.
I did test it a few times, yeah. But so back then you had noise-induced hearing loss as a result of working in industry and, your work background. But these days it's far less because of that. But I think maybe in your field it might be more likely. I mean, certainly musicians. I've not met a musician yet that's not got noise-induced hearing loss. But there probably are some out there somewhere.
I believe dentists have got quite high on the
drill,
the tinnitus list because of the drill.
Exactly, that loud pitch, high pitch. Again, the high pitches they're the ones that get damaged first. So they say more recreational than these days, and people need to be watching that. And even that's starting to sort of become less of an issue now, I think, as time because there's noise regulations within the recreational world.
And can I ask, sorry, so you would go back to occupation, you were talking about ear protection. And I imagine, yes, they brought the law out and, you must protect in certain occupational. But how good was the protection? And how good is it now?
It's not perfect. There's no way you can if you're in a very, very noisy environment, how you can filter out all of the noise and not have some impact,
And it's any impact that eventually can cause tinnitus.
Right, so with noise, there's two types of damage to the inner ear. There's sudden impact noise, like that. So that would be a gunshot, for example, next to you, or an explosion.
Yeah.
Now that will cause two types of damage. It will cause physical damage to the inner ear, these little hair cells again. It'll physically damage them, literally the sound coming in there, bang. And that physical damage will not repair. So that's instant, permanent damage.
Wow.
But the more common thing is this what we call temporary threshold shift to start with. That's where the hair cells are so overwhelmed with sound that they can't work anymore. They just go into stun mode. They can't recover. So they have to take time to recover. And that's where you get a sudden temporary hearing loss. But also you get that tinnitus as well. So if you come out of a nightclub at late at night, you hear that screeching tinnitus, your hearing's a bit dull. That's usually temporary threshold shift.
So, Chris, can you do anything about that? So, just for the listeners, if they feel, it's a temporary, can they encourage it to repair, come back?
Well, first of all, you shouldn't be getting to that stage in the first place, because once you start doing that and start getting that, it will naturally become permanent. It will naturally become that.
So that goes back to the wearing ear protection at gigs and concerts.
Exactly. You can't repair the inner ear once it's damaged. I mean, we'll obviously talk about that probably a little bit later about treatments for tinnitus and things and repair of the inner ear. So the best thing you can do at the moment is to not damage it in the first place.
Yeah.
Prevention's always better than cure, isn't
Certainly.
it? Yeah.
Yeah, absolutely.
So just whilst we're on that, so we've talked about kind of high pressure level, sound pressure levels and volumes and things like that. But can any underlying conditions like stress, hypertension or infections or anything like that trigger tinnitus?
Yeah. So let's go back along this pathway. So first of all, infections. Now the most common, you might have an ear infection, I was going to say ear, in the ear canal here. That will be like the wax, so that blocks up.
Okay.
Yeah. Now that in its own right might allow stuff that's already damaged further along to be more audible and cause tinnitus like that. Then there might be a middle ear infection, which is it's not very good. This showing the middle ear bit here, but in fact it's in the wrong place anyway. There like that. But the middle ear here is like a fluid-filled chamber, and this little bit at the back called the eustachian tube usually allows air to flow either side of the eardrum, because for the eardrum to go backwards and forwards it needs to be within air. If you've got fluid behind the back of the eardrum it can't move backwards and forwards.
Right.
It's a little bit like they always say, if you go into water in a car you can't just open the door, you've got to let the water in first. You've got to have the same medium on either side of the door or the eardrum for it to be able to move backwards and forwards. So if you've got a middle ear infection, or what's very common in children is otitis media, it's where you get this inflammation of fluid within the middle ear, and it usually originates because this tube here, the eustachian tube, has become blocked, because in kiddies it's very, very tiny, and that blockage can then lead to fluid build-up in the middle ear. It can happen with older people as well, though, especially where we live, where it's all damp and cold most of the time of the year. So that, again, not a cause of tinnitus, but it can allow stuff that's going on further along to become more audible.
Right.
So stress, that was a good question.
Yes. So, again, other seeds, so that's your seed. So other things that can allow that seed to grow, so soil, could say that was the soil potentially there. You also need sunlight, water. So stress could definitely be the sunlight that brings out tinnitus. And there's good reason for that. And that's going back to my quick analogy then of where I used to live. I used to live on the flight path into Manchester Airport. And we'd have all the sort of sounds of the planes going over all day. And people would come round and go, how do you put up with all that noise? And they go, what noise? Because you filter it out. Okay.
You'd learnt to get used to it almost.
Correct. Your brain adapts out because it's not important. It filters it out. However, the neighbours are back again. I can hear them because they're having another row. I can hear them. Now, the sound level, the intensity of the neighbours is nothing compared to those planes. But because there's a stress factor involved there, then they become more intense. So, good reason for that. Millions of years ago.
Association.
It's the way the brain adapts in terms of importance.
Okay.
So, going back millions of years ago, we'd be there tripping, let's say, through the jungle or whatever, and there's all that noise all around us. Suddenly there's a twig snaps over there. Now, last time we heard that twig snap, my mate got eaten by a moth or something. So it's important to hear that sound in all that other noise. So stress, first of all, if you're walking through the jungle, you're in a stress situation, so immediately you're heightened.
Yes.
Everything's on a more heightened alert. But sounds that are threatening need to be heard over the sounds that are non-threatening. And that is very important when we start to look at how treatments can help with tinnitus in terms of the more psychological approaches and how the pathways work for tinnitus, which is probably what we'll talk about, I think.
Yeah. Okay.
Thank you.
So let's say somebody's experiencing that. How is it diagnosed from your side of things?
Okay, so as I said before, by far the most common type of tinnitus is wear and tear inside the inner ear, which could be due to age, most commonly due to age and noise exposure. There are rarer examples. Example of, for instance, antibiotics, gentamicin could potentially cause damage to the inner ear. So, for example, in a newborn baby, going back there again, I know I seem to stuck to newborn babies today so far, but they could have damage to their inner ear as a result of gentamicin.
Right.
They might have had an infection when they were born and they're put on high levels of gentamicin. That can lead to damage of the ears. So what we do there, of course, is that test I talked about before, that
Yes.
otoacoustic emission, and that would tell us that there's some damage to the inner ear. So that is one test, but more normally with older people, your first thing you would do is do a hearing test.
Right.
Because more than likely the reason you've got the tinnitus is because you've got that damage to the inner ear and therefore you've got a hearing loss.
Right.
So the hearing test will be the first port of call for routine diagnostic assessment for tinnitus.
And sorry, and the hearing test will show that it is hair damage of age-related, of exposure.
Right. So first of all, age-related hearing loss is always high frequency. In fact, from very early on in life, you're already losing your hearing.
Yes.
So they used to have these speakers, didn't they, outside little supermarkets, and it would keep the teenagers away because they had this high-pitched squeal.
Yeah, hornets or something they were called, weren't they?
Right.
Yeah, I remember those.
And, of course, people who were slightly older wouldn't hear them at all, but for the young kids, it was like, not going there, it's too loud.
I think, sorry, we were talking about this, the cat, to keep the cats off your garden,
yes,
isn't it?
Yes,
The
that's
high
another
frequency.
do that. Yeah,
yes,
exactly,
yeah.
exactly. You can't hear it, but...
Yeah.
So even when you're younger, you're starting to lose your hearing. But that doesn't impact on speech, because speech... So going back to sound again, so we supposedly can hear from 20 hertz, so that's air moving backwards and forwards 20 times a second, up to 20 kilohertz, that's 20,000 times a second. But there's very few of us can actually hear up to that level, even when you're young. But that will gradually get worse and worse, and you'll hear less and less of those higher frequencies. Now, for speech, you need to be hearing anything from about the 200 hertz up to about 8 kilohertz. So once you start losing your hearing below 8 kilohertz, then you started struggling with hearing. So it starts usually in background noise, and people I'm like they're mumbling a bit. And the reason for that is because you're missing out on the high frequency speech sounds. So I'm mumbling a bit. So people will always come to me and they'll go, well, I can hear you, but I can't hear what you're saying. I said, that's because you're losing the high-pitched sounds. And usually it's the wife of the person who's sat in front of me will say, yeah, there you go. Whereas, the patients are always the last to know about this.
Yeah.
And, of course, having a hearing loss, certainly when I first started in the trade, you were put in front of someone, like myself, and I'd say, you've got a hearing loss, it's your age. I'm not that old, am I? Because age and hearing loss are like one step into the grave, isn't it? I'm not old enough to need hearing aids.
But as you mentioned before, tinnitus can affect at any age.
Absolutely.
Yeah.
And this is happening. So let's go back to what you was talking about before. So that wear and tear is happening. And so as that wear and tear happens, it can happen at any age. It could be provoked by certain things, like ear infections that could cause damage to the inner ear, smoking and blood supply changes as a result of that, and noise, as we talked about before. So, and also genetics, because some people inherit rather naff ears. It's simple as that.
A genetic predisposition.
Absolutely,
to problems.
yeah.
So hereditary patterns then can actually influence someone's
So many.
susceptibility to tinnitus at some
Yes,
point.
Absolutely,
Yeah, so
yeah.
many
I
different.
didn't know that.
fact-
My nana had tinnitus quite bad, but there you go.
So you don't know whether it's age, wear and tear, or mixed in with a few things.
Well, as I say, it won't be one single factor. It's a combination of factors. So you need to look at the whole factors, and that's where the treatment lies, really. It's looking at the whole thing.
So on the treatment, can you give us a brief overview of the current intervention?
Right, so the most current intervention, so as I said before, if it's wear and tear of the hair cells inside the ear, there's usually a hearing loss. And that hearing loss means that the nerves are still firing, but they're not getting the signal that you'd like them to. So what we do is we give a hearing aid that amplifies the sound, which then overcomes the damage of the hair cells, so the nerves start getting stimulated again. And by being stimulated again, that means that the volume inside the head turns down. The tinnitus can therefore be not one of a masked, but it's basically suppressed.
Yes.
To the point where it's not
So
noticeable.
you don't hear it as much, and then you
Exactly.
cope with it a bit better.
Yeah, absolutely. And also, there's an interesting thing called residual inhibition, where you take the hearing aid off, because the volume control inside your head's turned down, there's a period where you don't notice the tinnitus for a while. And it's funny with patients with tinnitus, you'll find there's different stages of where they're at. And you'll find that they're at there for a while without that tinnitus, and then you'll say, we'll start talking about tinnitus, and all of a sudden, oh, it's there again. That's
Yeah.
because you're listening in for it again, because then you're bringing it back to the centre stage, and that's the thing. It's all perceptual. A lot of perception involved in this work.
So you've put your attention on it, and then you hear it almost, isn't
Yeah,
it? It's so
yeah.
clever, the brain.
So going back to the treatment again. So the hearing aid bit's the first point of call.
Right.
Or taking wax out if the sound's not getting air in the first place. And then it's more the sort of the psychological thing that will affect perception. So if we could talk about perception, so perception breaks down into various things. So you've got non-awareness, because things are going on and you're not aware of them. It's like those planes I was talking about before. Awareness, that's, I'm aware of things in this room and I'm not directly focusing on them, but I can see there's a camera over there and a mic there and you over there.
Yeah.
Whereas I'm focusing on you, so my attention's on you.
Yeah.
And then take that a little bit further, I'm really obsessed with you now. That then becomes absorption.
Right.
When you're moving, so imagine if you're playing your guitars and someone's really loving what you're doing, to the point of nothing else happening, no awareness of anything else, that's absorption. So perception has different stages.
Right. Okay.
And
So that must be so hard for that individual that has the absorption of the tinnitus.
if they're absorbed with tinnitus,
Yes.
absolutely.
And how
How do you change that
yeah.
position? So, first of all, the absorption is because you've got some real neurological fascination for what's going on in front of you. So, for instance, the music that you're absorbed in is
Yeah.
because you're getting pleasure from that music.
Yes.
But that absorption might be a negative absorption as well, because it's the annoying neighbours next door, for example.
Yeah.
And so you've got to work on that absorption and change it. So the way I like to think, this is a bit of an analogy now we're going, but just imagine that you, as the perceiver, are in a big auditorium. Around you there's lots of people, and any of those people at any time could go onto the stage. Okay?
Right.
And those people could go onto the stage. If they're on the stage, they're in your area of awareness because you can see them on the stage because of the lighting of the stage. They might come to the centre and a spotlight might go on that person. And that spotlight on that person could then, lead to people having an absorption with that person playing their guitar or whatever it is.
Got you.
So at any time, any of these people could become that point of absorption. But because of what's going on around that person in terms of importance, the level of importance stipulates that is the important thing at that time that must be listened to because of stress. So, for example, the click of that sound, I need to hear that. That needs to be straight in in front of my lens there, because I need to know what I need to do about that. So, if we look at the brain and how it works a little bit, there's sort of various aspects. So, first of all, talk about the reptilian brain. That's a very, very old part of the brain. It's the reptiles and snakes were the first things that sort of crept onto the earth, off the sea, about 350 million years ago. So they've been around a long time. They've been very successful. That's because their brains work in a very, very specific way to do with survival. So they have what I call the F's. You've got the first of all, if you see another snake, you're going to freeze because you need to see what's going on here. What am I going to do? So freezing. Then you've got fighting. I'm going to have to fight this one off. Fleeing, I'm going to need to run away from it. Feeding, I might want to eat it because it might be food for me. Or the other F, which obviously is reproduction. So those Fs are really, really deeply ingrained into that reptilian brain, the limbic system as we call it. And that part of the brain is very heavily linked in with smell and taste. The smell and taste are the big things in reptiles, the tongue and everything.
Sorry, is the limbic system regulating our emotions?
Very much so, very much so.
And it's in our part of our brain.
Yeah, it's an emotional part of the brain. So what we've got, for example, the aromatherapy, that's a classic example of how it works. You've got the smell out there, and it immediately evokes memory, because you've got the memory in there, and the emotions. So that's how aromatherapy works. So I'll give you a negative example that used to bother me. When I was a young kid, I basically put my hand through a glass door and then my finger was basically severed off and it was all stitched back on again. And it was all done with a local, so it was actually quite interesting watching that. But when they came to take all the stitches out, this was awful. You wouldn't do that nowadays. They took them out without a local. I was only 7 at the time.
Gosh.
So they were pulling these stitches out. They weren't just skin stitches, they were through tendons and things.
Yeah.
the absolute pain, it was the biggest pain I'd ever felt in my life
I
to
can
that
imagine,
day.
yeah.
Crikey.
And the woman that was taking the stitches out was chewing Wrigley's spearmint gum. And every time I smelt spearmint gum after that, I felt pain.
Took you
literally.
back.
Yeah.
Instantly.
Another one's Heinz tomato soup. That's a lovely one, isn't it? That smell of, it takes you back to the warmth of your childhood.
Yeah.
So it's very, very emotional link.
It's like certain perfumes and aftershaves, isn't it? Some you just gravitate, and that person can become attractive because they've got that perfume on you.
And
like
that comes back to how the sales and how it
indeed.
consumerism fits.
Yeah. It's clever though, isn't
plays
it?
on all of that.
Our
doesn't it?
limbic system, gosh.
How does that link to tinnitus?
Yeah. Okay. So let's take it all back again now. So
Yeah,
we're
we
talking about stress.
It is Tinnitus Matters podcast.
Yeah,
Yes, Phil,
absolutely,
thanks for reminding us.
absolutely. So the stress, will impact on this system here because he's listening for that clicking sound there. So it's putting whatever's making that sound at the front of that stage. And because there's that emotive stuff going behind it, that immediately needs to come to the front of the stage.
Right, okay.
So there's an emotional link here to the tinnitus. Now, why is that? The emotional link to the tinnitus is because it's something that's going on in here. It's not out there. I've no control over it. You immediately start to think, I can't control this thing. I can't just go out the room because if I go out the room, it's still there.
So you can turn a television off, it's annoying you, but you can't turn your tinnitus off.
You can't just turn the tinnitus off just like that as a switch. So that becomes a threat. It becomes more like the annoying neighbours rather than the planes flying over. So you start focusing in on that more and that's that limbic system that has that very, very strong emotional hook on what you hear and what you perceive.
So how do you help that?
How do you help that? Well, that's where you need to start looking more at the psychological sides of things. And I think before we start doing that, you've got to look at the next level of the brain, the monkey brain, as I like to call it. And the monkey brain is basically the monkey see, monkey do sort of thing. As you can imagine a chimp's tea party there. It's higher level, but a monkey doesn't just operate like a snake that's sort of slithering around on its own. It has to interact with other monkeys. So there are certain things there, like affection, attraction, addiction, and then, obviously addiction's a bad example of that, but there's also other things like anxiety, anger, depression. That's the things that these monkeys can have, and those things, again, link into the tinnitus. So the tinnitus can eventually make you anxious, depressed, and vice versa. So you have a vicious loop going there between anxiety, depression, and dizziness. Tinnitus. Sorry, dizziness is my preferred field of talk, by the way. I'll get that one in at some stage today. So that feeds back in a really, really bad cycle. So sometimes treating someone's anxiety and depression can help patients with their tinnitus.
So would cognitive behavioural therapy
absolutely
help here if it's
CBT, looking and challenging people's perceptions of the tinnitus, changing it more from the annoying neighbours to the planes flying over it. Unimportant. It's something in that auditorium way back there that's not relevant, so it doesn't need to be on the stage.
And counselling?
Absolutely. Counselling again gives you more awareness of first of all, you need to know, is it something that's wrong, and that needs to be dealt with, that's important. So going back to causes of tinnitus, for example, if it's a pulsatile tinnitus, bum, 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 that could be originating from the vessels here, and that would definitely need some more investigation. Then if the tinnitus is just in one ear, says he's only got it over here at the moment, that might need investigating, because normally your ears, the same about genetics and noise, and we're exposed to the same genetics, the same noise, the same age. So normally the hearing deteriorates to the same degree in both ears. So normally you've got tinnitus in both ears. So if that is very much in one ear, again, we might need to look at what might be causing that, because it might just not just be wear and tear inside the ear.
So you need to go to your GP about all those factors first.
Most certainly.
Right. So that's important to the GP. When all that has been completed, that pathway, and hopefully everything is okay, you're then looking at options of hearing aids. You're looking at CBT, counselling. And what you're saying as well is knowledge is power.
Absolutely.
So the knowledge is the key.
Knowledge. First of all, if you get knowledge of the fact that it is just wear and tear inside the ears, that it's normal, that at least 2 of us in this, 3 of us have tinnitus. You're too young yet.
I do have tinnitus.
Oh, there we go.
Yeah.
That's 3 out. There you go. So
Yeah.
that shows how common it actually is.
Yep.
I'm not jumping on the bandwagon.
Yeah,
by the
no,
way.
it is extremely common.
So,
Sorry, go on.
oh, sorry. I was just going to off the back of what Christine's just asked. So you've gone to your GP, you've come to see yourselves or colleagues. You guys would help with the hearing aid side of things in the audiology departments of the NHS.
Yeah.
Who then sorts out the counselling? How do you end up with the CBT and the counselling?
So we can help with that as well, don't we? at
Yeah.
By
work?
referring?
No, we can do it in the department.
Right,
It
okay.
can be referred out depending on severity and so forth. There's also self-help we can guide them with as well. There's many charities out there that do support that. But we usually in the clinic can do like a one-on-one information giving along with some counselling as well, which I think is very beneficial, isn't it, to our patients?
Absolutely. So one
Very
thing
beneficial.
you know, Christine, but we introduced a direct referral service, and we're going on pathways now, but just very briefly, where patients were seen a lot sooner for their tinnitus. And rather than seeing GP and then GP, because the GP don't know what to do, you know, eventually they say, well, we'll send you to the ENT, and then you have to wait 6 months for ENT, then we'll send you to audiology, and it's just Coming directly to audiology in the first few weeks of presentation of tinnitus means that you're nipping it in the bud. So you're
Yes.
nipping it in the bud before people have these negative connotations of what it might mean.
Before it grows.
Exactly. To a point where it becomes that obsession, that absorption on the centre of your stage.
Yeah.
Immediately then it's easy to get it off the stage, literally, because it's an unimportant act to start with. You can get it off the stage a lot sooner. So that's the reason for these podcasts, really, is to try and get that awareness out to patients sooner. That the sooner you sort of have the awareness, diagnostic testing if needs be. You know, there are some weird and wonderful examples. So, for example, the middle ear, stapedial myoclonus, is where the stapedius muscle inside the middle ear is actually twitching, and that again is another example of potentially an objective form of tinnitus, because you can measure that one as well.
Which is rare, isn't it?
Very, very,
Yeah.
very rare.
But it's just always important just to
Anything that's
check.
out of the ordinary in terms of, if it's just straightforward, high frequency, bilateral, mild, sort of in the background tinnitus, yes, get your hearing checked. It's probably unlikely, you know, especially if you're not 21 anymore. You might need hearing aids, which would help not only just with your tinnitus, but obviously the hearing problem that you're probably not even aware of yet.
Well, that's really interesting, actually, that we've just kind of come round to that, which is seamless to my next question, actually, Chris, which is to do with public awareness about tinnitus. And what steps do you think should be taken to educate people at what ages and things like that about prevention and treatment?
Yeah. So prevention, certainly young people, you know, I mean, obviously, when you're young, you know, you don't think about the future, do you? And you
Nope.
don't, I mean, I'm the same. I used to go to heavy concerts and things when I was younger.
I know we always like to say in clinic, we can prevent, but we can't always cure.
Absolutely.
Yeah.
So it's so important that the earlier and the sooner we grasp prevention, the more chance we have.
The less chance of permanent damage, like we were talking about before, to the ear. You know, if you can protect that ear from an early age,
Yeah.
obviously, you know, I mean, you can get a little bit obsessed with that. You know, you've got to still live your life, haven't you? You know, and people do like music and things. But I am known for having the music rather loud in my car and everyone down the street know when I'm coming. You know, probably I should be a little bit more careful and take some of my own medicine here.
Yep.
Which is probably one of the reasons why I've got this screeching tinnitus now, which...
But it's
never
a
used to
balance,
have.
isn't it? I suppose.
It is, exactly. But, you know, it's awareness of the fact that, you know, if you don't look after your ears,
Yeah.
you know, not only will you get hearing loss, but you'll get the tinnitus, etc., etc. So there's looking after your ears. Yeah,
There's
it's
a lot
very
of
important.
avoidable then signs there, isn't there,
There
for
is.
us all?
So, in terms of kind of the future of tinnitus and the future of this kind of area, what research is there, or is there any kind of research that you're particularly excited about that you know is on the horizon, or who's doing it?
Yeah, okay, so the classic one is we think of the hair cells inside the inner ear. Could we not do something to let's say,
Regenerate?
regrow them?
Yeah.
Regrow the hair cells. So,
Is that looking likely?
right, so throughout my working life, I've been in the job 40 years now.
Wow.
it's always been about 10 years away.
Right.
So, admittedly, 10 years ago, it was in a test tube they could do this. And now, in 10 years' time, it's going to come, but we can actually do it in a rat now. We can do it but the problem is it's so delicate and sensitive and, very, very cleverly put together that.
Can I just as a side curveball here? Isn't there a pub quiz about the bones of the middle ear?
Oh, right, yeah, the malleus and the
Get
incus
that
and the
in
stapes.
it, yeah. They're the smallest bones.
They are the smallest
in the
bones in
body.
the body, yes.
For all your pub quizzes out there, I just wanted to share that.
That's golden.
But that shows how small it is, though, I think, as well.
Exactly, yeah.
Identifies. Is it the size of a small fingernail?
Exactly.
Those bones, clever.
Very
So,
clever.
Yeah.
so going back to the treatments again,
Sorry.
yeah, I have completely lost
I think what overwhelms me here whenever I relearn about the ear, talk about it, is how small it is, but how much it does.
Yes.
How much it does and how much it can lead to and how much we do need to look after it as well and respect the ears, because if we don't, it can lead to X, Y, and Z, and tinnitus being one of them. And a lot of the tinnitus you've discussed today could be prevented or could be prevented from growing.
Growing is the thing, as I say, going back to that seed again.
Yeah.
Because awareness of it, understanding that. I mean, I know that I've got this tinnitus, but I just know it's tinnitus. It's not important to me because I'm obviously having a more of an awareness, but it's not just having that conscious textbook awareness, it's having that experiential awareness.
Yeah.
So that's very, very important for treatment. Certainly, I think for an awful long time. So, for example, going back to treatments again, fixing the inner ear isn't an easy thing. There's lots of people out there at the moment saying we can squirt things into the ear to help regenerate and things. I think one thing that I should point out very clearly, though, if you get a very sudden hearing loss, I think it's very important that you get that checked out very, very quickly, because that might mean there might be some inflammation or a lack of blood supply to the inner ear. And if you can get that treated before the hair cells are damaged,
Yes.
they're just impaired, then you can prevent permanent damage.
Got you.
So it's very, very important, if you do lose your hearing very, very suddenly, that you get that seen very suddenly. Don't wait a week or two to see the GP because they think it might be wax, and then the GP says, oh no, it's not wax, you better go and see that. Do take that very, very seriously.
Yep.
I mean, sometimes they recommend you go into your local A&E
Correct.
walk-in centre.
Absolutely.
Where they can prescribe, can't they?
Yeah,
straight
steroid
away?
treatment to try and reduce inflammation, or various treatments to increase the blood supply back to the ear again. So that's the thing, and going back to that prevention, because the fix isn't that easy when it comes to the inner ear. So then we sort of move up the pathway a little bit, sort of fixes that are sort of the current in vogue. I think the most current in vogue at the moment is bimodal neural stimulation. So what we've got is, so we talked about before about hearing aids.
So, Chris, is this potential research?
This is stuff that's in the field at the moment.
So
It's being
possible
researched.
hopes.
Oh yeah. I mean, at the end of the day, I'm just saying this is what's current. In all honesty, my personal belief is it's well, I'll come on to that in a little bit. But just the theory behind what this is. So first of all, with maskers and things and sound enrichment, that's just overcoming that problem there. But what we can, this is the theory, is if we could stimulate the cochlea and get sound stimuli going up, and also use other stimuli. So one example is using the tongue and stimulating in two ways. It's the old adage of, the nerves that fire together wire together. And the theory is, therefore, you can change people's higher level conscious perception of what that tinnitus is. You could turn it into something more pleasurable at a higher level. That's the theory behind bimodal neural stimulation. So that's one thing that's current vogue. Another one is transcranial direct current stimulation. And what that basically means is you stick a 9-volt battery across the head. You're basically stimulating the prefrontal dorsal cortex there, and it's electrode that you stick on your head, and that direct current, it's a battery, is stimulating across that part of the brain. It's commonly used now. Well, when I say commonly, it's not that common. It's used for people who've got depression that's not particularly treatable by the usual SSRIs, the
I was
usual
going to say that
antidepressants.
sounds like something they did in the 1960s.
So yeah, so you've got ECT, which to be honest with you is still used.
Right.
You know,
Wow.
and
Crikey.
ECT being, just for our listeners.
Sorry, go on. ECT, electroconvulsive therapy, and it's you know, you see these films of people, you know, being electrocuted and things, and certainly my mum used to suffer from real bad depression, and she used to have ECT, but back then, you know, you couldn't do this these days. They said, we're giving you sleeping therapy, Mrs. Brockbank, and basically what they were, she were putting her to sleep and then zapped her head. With the large amounts of electric current, the idea being to reset the nerve pathways
To stop the depression
yeah,
and
yeah,
anxiety.
Right.
And they were all put in like institutions.
Well, it was a lot,
wasn't there?
Yeah, I mean, obviously, you know, you had Whittingham, for example.
Yeah.
But ECT still exists for people with intractable depression. It is still a valid treatment, but don't get me wrong, I don't think they do it like they did to my mother anymore.
Yeah.
Having said that, what I'm talking about here isn't very large current. We're talking 9-volt battery, you know, very, very small level. I've had this system on my head before now, and it's more like a mild tingling, at worst a mild sensation of a burn, but very, very low level. And you just sit there reading a book or whatever while this thing's happening.
So does it work?
Right, well, first of all, does it work for depression? Well, I had it because I suffer from depression. Did it work? No, I'll be perfectly honest. For me, it didn't work.
Did it help your tinnitus?
Well, no, because to be honest with you, I've only had the tinnitus for the last year or so that I've been aware
so
of.
it's hard to measure
But
it.
when you think about it, what I think might be going on there is it's not treating the tinnitus, it's treating the underlying depression that's again, it's that seed and water and sunlight, taking away a bit of the sunlight so it can have an effect there. That's the theory, but it's all very theoretical. My view is, no, I don't think it will. And I don't think that, I mean, there's people out there selling all this latest stuff, bimodal neural stimulation. It might help a little bit. But to be honest with you, the most important stuff is understanding it at the beginning, the awareness of what's causing it, hearing aids, basic good old hearing aids, basic awareness, understanding brought
Sound
about
therapy.
by therapy,
Yeah.
sound therapy, all these sorts of things. They're sort of better than anything that
I
we've
feel
got.
that
you know.
they kind of help with all the different kinds of tinnitus
Yes.
more than this research that you're talking about. Yes, it's exciting, but it's more specific to certain tinnitus.
Absolutely, and it's to make it generalisable and make it profitable for these companies to treat, you know, all people who've got age-related hearing loss, tinnitus. It's going to be very difficult for them to, I think, to achieve that.
Right.
Well, that has been fascinating.
Fascinating, Chris. Thank you very much
Thank you
indeed.
so much
No
for
problem.
talking today
Thank you for having me along.
to us and our listeners. And I
Yes.
think you couldn't deny you've learnt something.
I
from
I
that
thought I knew a
information.
lot about tinnitus before we started
Yeah.
this episode, and can I just say I've just learned so much by listening to you. So thank you very
You're
much
welcome.
indeed.
You're welcome.
Yeah, we're really grateful, and we'd love to invite you again sometime. And sounds like there's so many areas we could discuss here
Certainly.
within the science. So
Yeah, certainly can delve into a little bit
yeah,
more.
thank you, Chris. That's
You're
great.
welcome.
Thank you very much indeed, and we'll be back for another episode of Tinnitus Matters at some point soon. So thank you very much.
Thank you.